Disclosures of for myself or any of the faculty. This is information about the CME. So we will talk about managing co-occurring alcohol use disorder. The objectives today, I'll add one to this, are to employ some screening tools for risky alcohol use and alcohol use disorder, learning the signs and symptoms of alcohol withdrawal, and properly managing it. And then we'll spend a fair amount, though, on becoming familiar with the FDA approved and some non-FDA approved medications, as well as briefly touch upon some psychosocial interventions. And I'm just going to start with a case to kind of set the stage here. So this is a patient, Ms. A, who's a 41-year-old female and has a history of hypertension and opioid use disorder, and presents to clinic for routine follow-up on her blood pressure. She's taking buprenorphine, HCTZ, and lisinopril, and tries to follow a low sodium diet and exercise regularly. She did quit smoking 2 years ago, but does report daily alcohol use. And on physical exam, her blood pressure is a bit high at 154/98, and then the rest of her exam is essentially normal. So you're concerned that her blood pressure could be due to, could be uncontrolled due to her alcohol use. And how do we determine if she has a pattern of risky drinking or does she have alcohol use disorder? So we're just going to briefly review some definitions here. So in the United States, a standard drink is 0.6 fluid ounces, which is the equivalent of 14 grams of alcohol. And you can see here some of the amounts when people are reporting beer, liquor, wine, spirits. And this is important mainly because if you ask your patient how many drinks per day, we want to make sure that we know how many standard drinks, right? And so if they're having a larger than 5-ounce glass of wine, for instance, that may represent more than one drink. So what is risky drinking? As defined by the National Institute on Alcohol Abuse and Alcoholism, it is, and this is the definition for adults who are not pregnant, the following quantities count as low risk for developing an alcohol use disorder. So for women, this is no more than 3 drinks in one day and no more than 7 in 1 week. So importantly, that and there, because if they're having 2 per day, let's say, but every day of the week, that would in itself be more than the 7 drink total. And then for men, no more than 4 drinks in one day and no more than 14 in 1 week. So let's talk about SBIRT, which is a very important intervention, screening, brief intervention, referral to treatment. This has a large body of evidence, especially in primary care. I think it was first developed in emergency room settings. It's a grade B recommendation by USPSTF, meaning that it's covered by Medicaid and Medicare. And it can be administered in a variety of settings and by a variety of health professionals. But again, the evidence is strongest in primary care. And it basically employs the 5 A's approach of asking about use, advising the patient about their use, assessing their interest in treatment, assisting them to get into treatment if needed, and arranging that. Sessions last anywhere from 5 to 20 minutes. And really the goal here is to reduce the negative consequences of use. So it's really a harm reduction method that's been shown to be very effective. So for screening, we start with a single question, and you've probably seen this, I think, on hopefully on clinical forms. How many times in the past year have you had for men 5 or for women 4 more drinks in a day? Because that would indicate a binge use pattern. And this has a relatively high sensitivity and specificity. Now, if the result of this one question is positive, then you can assess their severity or their risk using another validated method, such as the audit C, which is briefer, 3 questions, or other validated method. Here you can see some more specific tools for certain populations. So the MASS-G for the geriatric population has a sensitivity of 93%, and CRAFT for adolescents. This is what the CRAFT is, and it's really just making it more relatable for the adolescent population. So you can consider using kind of a lead-in perhaps for younger children, younger adolescents about their friends' use. Really important to avoid ambiguity. So really being very straightforward. In the past 12 months, did you drink any alcohol? And really any youth with a positive answer should then proceed with this validated tool, the CRAFT. So standing for, have you ever ridden in a car driven by someone using? Do you ever use alcohol or drugs related to relax, fit in more? Do you ever use alcohol or drugs alone? Do you ever forget things while using alcohol or drugs? Have your family or friends told you to cut down, and have you gotten into trouble while using? So back to our patient, she responds yes to that single question regarding heavy alcohol use once in the past year. So you do administer the audit C, which I'll show you, I think in the next slide here, and she scores a 7. So, and we'll go into that scoring as well. But on further discussion, you learn that she's really afraid of stopping because she's had prior episodes of withdrawal 2 years ago, which resolved with return to alcohol. And it's also interfering with her home life and work, and she asks for your help. So you'll see here too that we're getting the screening for risky drinking, and also it looks like she's meeting criteria for alcohol use disorder. Here's her audit C. So you can see that in this case, the patient circled that she's having a drink containing alcohol 4 or more times a week, which gives her a score of 4 for that question. And a 1 score she gets for how many drinks containing alcohol on a typical day. She has 3 or 4. And then how often do you have 6 or more drinks on one occasion monthly? And you can see here that a score of at least 4 identifies 86% of men, and a score of at least 2, over 2, identifies 84% of women. Now, how do we know if our patient needs a treatment, right, for alcohol use disorder? And in her case, sorry, I'm not able to get the, there we go. In her case, she did mention at least 2 of the criteria, right? We saw consequences, it's interfering with her work. She's also craving it, and she's had withdrawal symptoms where she's basically needing to take it to not experience those. So anytime that then you identify alcohol use disorder, the key is offering treatment. Treatment rates are traditionally very low for alcohol use disorder. Only about 6.5% of adults and 5% of youth in the past year received treatment. Less than 1 in 10 people in the US with a diagnosis in the last year received any treatment. The community programs, excluding the VA, really the vast majority, over 90%, offer only group counseling and referral to AA, so minus the medication component, and one-on-one counseling. And importantly, and sadly, racial and ethnic minorities do experience barriers to these mutual help groups, and in general do demonstrate much lower treatment utilization, and we see this especially by women. So here you can again see kind of the need to expand our treatment. Now, what are our options? Really, when thinking of treating alcohol use disorder, you can think of this in terms of 2 main aspects. One is going to be, and then of course the therapy as well, but we're talking about the medication first here. So managing the acute withdrawal if they're experiencing that, and then medication to help prevent relapse. And so we'll talk about these medications. In management of acute withdrawal, really the key here is determining if they are safe to have an outpatient taper. And if they have had, for instance, prior seizure, they don't have a supportive environment, they've had some sort of medical comorbidity that would make it quite dangerous to have outpatient. Sorry, I'm going to try to close this so it doesn't make noise. Sorry. There we go. Then you'd want to be directing them to inpatient. We do realize that, especially in our communities, I think that it is very hard to have this inpatient service, but it is still important that we try to determine their level of risk for seizure. If you do determine that they are okay and safe to have an outpatient management, then a brief benzotaper is what is recommended, and that's usually by brief 5, no more than 7 days if possible. And then gabapentin and carbamazepine can be considered to help with the symptoms of alcohol withdrawal, but not for seizure prevention. And then we'll talk about the FDA approved medications in more detail in a minute, the naltrexone, acamprosate, and disulfiram, which is Antabuse, and then touch upon briefly some off-label medications. This is pretty small, but this is just to give you a sense of the CWA scale that can also help determine risk, and it's based on a number of subjective and objective findings. And a higher score, certainly above 18, really has increased risk of withdrawal seizure, and so it would also come into play in terms of determining that outpatient versus inpatient management. So again, back to that first branch of acute management of withdrawal. Here we see the evidence for the benzodiazepine prevention. A 2010 Cochrane review of 64 RCTs showed that benzodiazepines are effective against alcohol withdrawal seizure when compared to placebo. There's not sufficient evidence for the use of anticonvulsants. So for instance, the carbamazepine, gabapentin, but they did find that carbamazepine may be more effective when compared, for instance, to these benzodiazepines, oxazepam and lorazepam, in treating certain aspects of alcohol withdrawal, some of the more uncomfortable symptoms for the patient, but again, not the seizure. And then it may also help decrease drinking extent after detox. And so in some situations, we are prescribing a 4 to 6 week taper when indicated of carbamazepine. And there may be a role for gabapentin as well in mild withdrawal, and has been found also in the evidence. And this is usually at doses that are slightly higher, 900 to 1800 milligrams. So back to our patient, we assess her further and we administer that CWA scale looking at her symptoms, and she scores a 12. So she's in withdrawal, but not severe. She does not have a history of head injury or seizure, and she's not pregnant, and she has support at home. So we review her options of inpatient versus outpatient, discuss the risks, but agree with her decision that for an outpatient detox, that she can go ahead with that. So we provide her that 5-day course in her case, she does not have underlying liver disease. We prescribed a 5-day course of Librium, which is a longer acting benzodiazepine, but certainly other ones that are can be helpful in a taper would be lorazepam, for instance, or oxazepam, but that's less available. And then she returns, but she reports, despite being able to get off of the alcohol safely, she has very strong urges to drink. So what is the most evidence-based medication that we have for relapse prevention? And this is naltrexone. So this is our opioid antagonist that is also approved for opioid use disorder and has evidence in the long-acting form for opioid use disorder. However, it has good evidence in the PO, the oral form, for alcohol use disorder. The FDA-approved daily dose is 50 milligrams. It's contraindicated in someone who's on opioids. So for instance, in our patient who's taking buprenorphine, because it blocks that receptor, right? So it can precipitate withdrawal. And we do need baseline and monitoring of liver function. It can be started while someone is drinking. So we could have, if she wasn't on buprenorphine, have started it perhaps even before seeing her back. And it's been shown to decrease craving, and it's really that a euphoria that's experienced with alcohol because of the generation of that opioid in the brain, because it blocks that and the chances of an extended relapse. So basically, if someone reports that they may be drinking 5 drinks a day, if they're on naltrexone, they may have a lapse to drink 1 drink, but the idea is the naltrexone would block sort of that enjoyment and prevent them from having that lapse turn into more extensive relapse. A Cochrane review of 50 RCTs, about 8,000 patients, showed that oral naltrexone decreased the relapse to heavy drinking to 83%. Of the placebo risk, and decreased drinking days by 4% and heavy drinking days by 3%. It's very well supported by the COMBINE study, which you may have heard about. This is the largest controlled pharmacotherapy clinical trial for treatment of alcohol use disorder. And basically what this did was it randomly assigned people to one of several branches to placebo plus minus acamprosate, which we'll go into as well, naltrexone, and then all of these had medical counseling, so just in the visit with the provider. But half of the patients received up to 20 CBI sessions with the therapist. And it was found that those with naltrexone and medical management and those with placebo plus that CBI had the most substantial decrease in days drinking. So this really provides great support for prescribing naltrexone in primary care settings. Acamprosate is our second FDA-approved medication that has a fair amount of evidence, mainly from studies out of Europe. It's an amino acid derivative. It increases GABA transmission, and it's thought to promote abstinence by alleviating some of the physical and psychological symptoms. As with naltrexone, it can be started while someone is still drinking, but most of the evidence is for when it started a couple weeks after cessation. It is not metabolized by the liver, so this is helpful in folks who have significant liver disease. We do need to follow their renal function. It is a little harder to take because the daily dose is sort of these 2 pills 3 times a day, which can be divided to 3 twice a day if that dosing schedule is difficult, but a little harder to take with that schedule. Cochrane review of 24 trials showed that acamprosate decreased relapse to alcohol when compared with placebo with a number needed to treat of 9. And its most important role seems to be in preventing relapse again in someone who's already abstinent. Just to touch upon our third FDA-approved medication briefly, disulfiram, otherwise known as Antabuse. This is the one that does cause that disulfiram ethanol reaction, which is very uncomfortable. When someone comes into any contact with alcohol, it does require liver function monitoring frequently. And it's really contraindicated, of course, if someone doesn't have a goal of total abstinence because of that sickness. So it can't be started within 48 hours of their last drink. It really doesn't have good evidence for its efficacy, but it's likely best if taken under supervision. And then we'll just touch upon briefly some off-label medications for alcohol use disorder. For relapse prevention. One is topiramate. This has fairly good evidence from 7 RCTs showing more days abstinence and less frequency of binge drinking than placebo. Has to kind of be scaled up in terms of its dosing. So you can start at 25 milligrams BID with a goal dose of 100 twice a day. Importantly, women must be on birth control for this. Medication, and it can have significant side effects ranging from paresthesias to concentration issues to kidney stones. The other one, which I would say I see prescribed much more frequently as an adjunct medication, is gabapentin, and it has shown effect on the percentage of heavy drinking days. The target dose that's likely to show this effect is 1,200. Sorry, I think I misspoke before. I said 900, 1,200 to 1,800 milligrams per day. And you do have to practice some caution in monitoring because it does have some potential for misuse. So what do the current American Psychiatric Association guidelines say? Naltrexone and acamprosate are recommended for treatment of moderate to severe alcohol use disorder. And then they suggest the use of topiramate and gabapentin in patients with alcohol use disorder, but usually after first trying naltrexone or acamprosate. And again, that disulfiram really should not be used as first-line treatment. So how do we decide which medication to take? Again, you want to consider the coexisting medical comorbidities, right? So for instance, in our patient, if she's on opioids, and that would exclude naltrexone as an option, considering if they have, say, severe renal disease, perhaps not acamprosate. So things to consider with their medical history. Also, what are their prior treatment experiences? Perhaps something has been successful in the past, and you want to consider that one again, or not if it was already tried. What is their ability to take a medication at a certain frequency? Naltrexone does come in that long-acting monthly form, which is also an option that can be quite beneficial. And sometimes can consider it if someone does have co-occurring opioid use disorder and for a certain reason may not want to be on buprenorphine or methadone, then perhaps that helps treat both. You can consider their psychiatric comorbidities as well. And again, remember that we need to treat the co-occurring mood and substance use disorders. The one trial of 170 patients showed that there was a significantly higher rate of abstinence in patients who had co-occurring depression and alcohol use disorder if they were treated with naltrexone and sertraline than being on either alone. And then lastly, I'm just going to touch upon some of these behavioral interventions for alcohol use disorder. So brief intervention, which we've discussed somewhat already, has a lot of evidence. A meta-analysis of 34 studies, over 15,000 individuals, showed that those who were receiving brief intervention ingested about 1.5 standard drinks less than those in the non-intervention groups after 1 year. And there's really little difference in the frequency of drinking or binge drinking, but just that amount. The features that are offered in brief interventions include feedback, responsibility, advice, providing a menu of options, and really addressing empathy and self-efficacy. And really, these interventions have been shown to lead to a 20 to 30% reduction in heavy drinking, and that there's really been significant effect found for up to 2 years in some of these studies. So that is a really important one that again can be employed by many different health professionals in many settings, especially with evidence in primary care. And then, of course, motivational interviewing has plenty of evidence. At least 32 studies have shown benefit of using MI in the treatment of alcohol use disorder. It's found to be most effective during the first 3 months and with younger populations who have occasional heavy drinking but low clinical dependence. So also, I think in treatment of alcohol use disorder, I think I would also say certainly for risky drinking that perhaps hasn't quite developed into alcohol use disorder. As far as mutual help in AA, it has been shown that increasing AA attendance tends to increase days off alcohol at both 3 and 15-month follow-up. However, Cochrane review of 8 trials didn't show evidence of efficacy as a standalone intervention. So again, going back to that fact that in treatment in the US, really at least 90% of community programs are offering only group and AA. We probably definitely have to put more effort into our community programs to expand the methods that are available. And then family involvement, when this is an option, this is a good one to turn to as well in many instances, as it has been shown to reduce drinking in 5 trials. So if you have a patient who expresses that they do have support in their family, this is good to offer involvement of the family in their treatment. So to close our case, going back to our patient, we obtained baseline renal function tests as she and you have opted to start a Camprosate, and she's basically, you can start it at the goal dose, but she titrated up right away to that. So you see it's sort of a strange dose there. It's 666 milligrams 3 times a day. You encourage her to keep taking the medication. And she agrees to meet with our psychologist for CBT. And at her 1-month follow-up, she reports that she did have 1 lapse last week with 1 glass of wine, 1 5-ounce glass. But this did not lead to relapse, and she's not had alcohol since then. And her blood pressure has also normalized. She's screened positive for depression. And you do decide to add sertraline to her regimen. She reports improvement in mood and length of time off alcohol. So in summary, please remember to screen youth and adults for alcohol use disorder on a routine basis using these validated tools, and be able to diagnose risky drinking and alcohol use disorder and offer treatment promptly. Alcohol use disorder is one of the most undertreated health conditions. I think it's like number 30 on the list of chronic disease that receives treatment in the US, but it does account for significant morbidity and mortality. We reviewed assessing their withdrawal risk and recognizing the need for inpatient versus outpatient treatment, and being able to counsel patients regarding different treatment modalities and offer them. And that is it. I will stop the share